Here I'm punching through that papilla, sounding tube bone, so we're measuring the distance from the alveolar bone to the tip of the papilla. We're also measuring the distance from the alveolar bone to the base of the contact point. We're also following these patients radiographically as well. So we take a small 3-millimeter punch biopsy, usually from distal to the second molar. The biopsy is placed in a little vial, sent to the laboratory. It takes 2 to 3 weeks to create a cell line and approximately 4 to 6 weeks of incubation to generate 20 million cells per ml. Before these are delivered back to us, they are banked and they can be kept virtually indefinitely in liquid nitrogen, allowing kind of a fountain of youth effect. It's kind of neat, you know, that I could take my daughter's 17-year-old fibroblasts and we can then bank them, and then when she's 40 and she wants to do something about that crow feed, she can use then her 17-year-old fibroblasts. They're then sent back to us in a little thermos, and if they, again, what we have here is not collagen. This is 99.5% pure fibroblasts, and if they're injected within the first 12 hours, they're 95% viable. Within the first 48 hours, 85% viable. But, you know, I don't think there's a dentist in the audience that wonders, okay, how are you going to inject that into the papilla and make much of a difference? Because all of us have injected local anesthetic in papilla, and you know that you can't get much volume into that bound down tissue. Well, of course, we face that problem as well, and in an effort to overcome that, we created what we're terming the papilla priming procedure. Again, those of you who do surgery, you know when you see that patient at 7 days, especially if you've done a graft, the graft is swollen, maybe the interproximal spaces are feeling great, and you feel like you're a hero. Well, you also know that that swelling goes down. How can we then use that transient phenomena and turn it to our advantage? So we're going in at the alveolar crest with an Orban knife, basically pivoting that off of the alveolar crest, creating a little space. We then go in with a curette and follow the alveolar crest to the lingual, again, just creating a space here, then taking a 12B blade and going down the papilla, not excising through it, but going down toward the tip so that we have somewhat of a little T lesion. What that allows us to do then is to create a little space here and allow our injection to get into all the components of papilla, the bone, the periosteum, and the soft tissue components. So if you follow this papilla priming procedure over time, here it's at day 0, here we've completed the procedure I just showed you, and you note now at 7 days you have some tissue swelling. But if you don't do anything, at 21 days, it's all back to normal. Again, I think if we think about what's going on here on a wound healing level, it might make it more sense. If we think about what the phases of wound healing, that typically most people think that wound healing has 3 distinct phases: the inflammation phase, granulation tissue formation phase, and matrix formation and remodeling. And when you look at a temporal example of this, it looks highly structured. But in reality, in nature, these different phases can overlap a great deal, and the time necessary for each of these phases can change a great deal. So can we manipulate this then to our advantage? Well, if we do our papilla priming procedure, within seconds of our papilla priming procedure, plasma proteins, primarily fibrinogen, coats the wound surface, and the process of wound repair begins. Within an hour of that papilla priming procedure, we begin the early component of the inflammatory phase. Neutrophils begin to come into this area, beginning to engorge the lesion, and within 12 hours, we see swelling of the lesion beyond baseline. So we now have swelling in our papilla. Also at about 12 hours, we're seeing the production of the natural fibroblasts to begin to increase. At 3 days, we move from the early to the late component of the inflammation phase. You see that we continue to maintain swelling over baseline, but it's looking a little bit different. We're finding that the neutrophils are being replaced by macrophages, and the macrophages are producing growth factors that are supporting matrix deposition, fibroblast production, angiogenesis, and we continue to be swollen. At around 5 days, we begin to enter into the granulation tissue formation phase. The natural production or increase in the production of native fibroblasts begins to peak at around 5 to 7 days. And along with that peaking of fibroblasts, the collagen accumulation that comes along with it begins to plateau. Then we begin to see wound contraction, and at 21 days, the wound is healed. And in our case, because this was a controlled surgical insult, we're back to where we were before. Well, how can we take this and turn it to our advantage? As a rule of thumb, most people feel that the amount of tissue you either gain or lose in a wound depends on the length of the granulation tissue formation phase. For example, in a wound where tissue is lost, generally you have a very short granulation tissue phase. And the bottom line is that the production of native fibroblasts and the collagen accumulation can't keep up with the amount of tissue lost in the wound, and you have a net loss of tissue. If we could do something to expand that granulation tissue phase, then theoretically we could end up with a greater amount of tissue at the end than we had at the beginning. And that's what we're going to try to do by infusing the patient's own fibroblasts at certain points during this healing process. So we do our biopsy, we do our papilla priming procedure, and we time our first injection at 5 to 7 days. We time it at 5 to 7 days because that's the point at which the body is beginning to, the native production of fibroblasts is beginning to wane. So we want to infuse it with either an injection of 20 million cells per ml of fibroblasts or with our placebo. Here's what it looks like. This happens to be the second injection on this patient, and it looks very much like what you would see when you inject local anesthetic. Keep an eye on the papilla. You see it begin to blanch as I'm injecting the cells into the papilla here. I find that I can inject somewhere between 0.3 to 0.4 mLs into the papilla. That translates to about 6 to 8 million cells, million fibroblasts that we're injecting into the papilla. Now, we're not just injecting it once, we are dosing this. Dosing schedules are common in medicine and in tissue engineering, not something we typically do in dentistry. But again, we're timing these at around 7 to 10 days. We're coming back and we're hitting these papilla again with another series of injections, trying to extend this granulation tissue phase out and trying to gain tissue. Now, if we look at the medical literature using this material, this is a slide on dermal depressions where they've taken dermal depressions, they're injecting the same material into the dermal depressions, and here's a biopsy at 6 months. You see here more fibroblasts, more collagen, no signs of inflammation. They've taken these same cells in animal studies, labeled them, and found that the cells are still present and active at 5 months, producing fibrinogen, elastin, glycosaminoglycans, collagen, increasing the dermal thickness. And where they've taken punch biopsies in humans, they find the dermis is thicker. Mechanism of action is that these fibroblasts, they are incorporated into the natural architecture of the dermis and then begin to either stimulate native fibroblasts to produce more collagen or undergo nascent production of collagen themselves. So our experimental concept is that we're going to come in and we're going to infuse the patient's own fibroblasts at critical points, hoping to increase the granulation tissue formation phase and result in more soft tissue growth in the papilla region. We're following these patients at an acute endpoint of 4 months and then following them to 12 months. We're looking into that for 2 reasons. We want to see what we get at 4 months, do we maintain it to 12 months? But also, theoretically, we may see an increase from the 4-month to the 12-month, even though we've not done any other injections. Again, if you look at the dermatologic studies and some of the plastic studies that they follow for 6 months, they find that they are getting an improvement at the 6 months from what they had at the 3 months, even though no further injections took place. Again, the idea is these fibroblasts are injected in, they undergo 1 or 2 mitotic replications, whatever the host needs, and then they set and produce de novo production of collagen, either sustaining or perhaps even improving the result over time. I'll just share with you a few cases that we have. This is a 4-month post-third injection. This is how the patient presented initially. You can see the papillary insufficiency, and you can see where we're at here. Another patient 3 months after the third injection. Again, you can see the blunting of the papilla here initially, and you can see what we're getting as it's filling in here 3 months after the third injection. Again, another patient baseline at third injection and 2 months following the third injection, seeing a nice progression of tissue fill into the papilla region. Another patient looking at baseline, almost complete blunting of the papilla here. You see it starting to fill in at the third injection. This is 2 months post-third injection. And note not just how the tissue is coming toward the contact point, but note what appears to be the volume increase. You know, this is a three-dimensional increase, not just a two-dimensional change. Another patient, baseline, 3 months, and pretty much complete fill of the papilla. And again, a significant volumetric increase in the papilla 2 months post-third injection. And the patient that I showed you initially, here she is 2 months post-third injection, and you can see the change that we have at this point. So we have to ask ourselves, you know, what's our new grafting instruments going to be in the future? And I think as far as conclusions, the combination of the TCP plus a recombinant PDGF in intrabony defects appears to be a very positive thing. The study, 6-month study, showed that we have statistical improvement in cow gain at 3 months, more rapid cow gain, and it's maintained over time, that our bone growth is certainly affected by this in a positive way. I look forward to using this on my patients in the future outside the study. If we look at the growth factor plus scaffold versus connect tissue graft, you know, we don't know. Looks interesting. Check with me next year and I'll tell you about that one. And same thing with the autologous cultured fibroblasts. This is really looking at something completely different than we've done in the past, looking at it in a different way. I think we're going to be doing that in periodontics. We're going to be managing things in different ways than we've done in the past, and hopefully that will result for not only growth areas for our specialty, which we certainly need, but also, and more important, predictability for our patients in ways that we couldn't have imagined years ago. So it's been my pleasure to be here with you this morning. We appreciate you coming out on the last day of the meeting, and I look forward to any questions that you may have in just a moment.